everyone. Welcome to today's series session. Today's critical appraisal is going to be on an observational harm study. We'll go into the scenario first. A 70-year-old male who has a known case of Alzheimer's disease with mild severity, MMSE score is 23. He was on non-pharmacological therapy and review was brought by his son with complaints of intermittent agitation, more during evenings and nights. So he understands that this is a progression of the disease and now wants to consider options for treatment of the same with pharmacotherapy, but is worried about the harms, especially risk of falls and fractures. So as a treating physician, you would like to discuss the risks associated with the antipsychotic use before initiation. So what is the evidence to report the risks of falls and fracture? For this scenario, I've looked at an article which is published in the APPRAISER. This article reads multiple adverse outcomes associated with antipsychotic use in people with dementia, a population-based matched cohort study. So we'll be critically appraising this study. So I'll be critically appraising using task questionnaire. So section A says, are the results of the study valid? So did the study address a clearly focused issue? For that we'll go into the required statement. So the population who included were adults who were more than or equal to 50 years of age with the diagnosis of dementia between January 1, 1998 to May 31, 2018. The exposure which they mentioned is antipsychotic use, both typical and atypical antipsychotics. The control of the comparator they used is randomly selected patients who have the same date of first dementia diagnosis or up to 56 days after, who had not been prescribed antipsychotics before the diagnosis. The outcome they look for is the multiple outcomes, singular outcomes which they look for are stroke, venous thrombosis, mode, DVT and pulmonary embolism, MI, heart failure, ventricular arrhythmias, fractures, pneumonia and AKI. The time period of follow-up for the whole study was done for 2 years. The setting is, this is based on the data which they have gained from people who have been registered in the primary care system in the UK, which is the clinical practice research data. From there, who had followed up in hospitals, even in multi-specialty hospitals, are still included. So the setting is both primary and specialty hospitals. The study design is a matched cohort design, which is a retrospective cohort study. So the cohort recruited in an acceptable way. So the answer is yes. So they had two cohorts. The CPRD, which is the database which I told, had two cohorts, which are Aurum and Gold cohorts, with two separate databases, which had some duplicate, but they have identified correctly and removed those. We'll come to that later. So the inclusion criteria for the patients who are recruited were patients aged 50 years or over at the time of dementia diagnosis, should have been registered with the CPRD for practice. UK states that almost 98% of the population are registered into CPRD. Should not be prescribed an antipsychotic in the 365 days before their first dementia cohort. So should have had records that were eligible for linkage to hospital episodes. So they reviewed all records. They should have had the index date of diagnosis, the prescription date, and the outcome date in the data. So the exclusion criteria which they mentioned, patients should have not been on an anticholinergic prescription before their first dementia cohort. And the history of a specific outcome, we had multiple outcomes. They had one outcome, they were not considered for that outcome alone. But for other outcomes, they were included for the data statistics. Why is that? Patient can have multiple outcomes with respect to a drug itself. So they had included them for that specific outcome. Other outcomes, if they have not happened there.
There is a tricky thing. Usually a cohort study, the rule is you're following a group of patients who have something in common, dementia, till they get an outcome, whatever, fall. They say fall is a primary outcome. At the baseline, if they had fall, you can't, because they already had fall, you can't say that the drug caused the fall. But because you have multiple outcomes, you're saying, for the cohort which was, if they had fall, I won't include them. But if they had some psychosis in the beginning, I would include them, but I won't include them when I'm analyzing the fall data. So they are doing some, it's a bit tricky. Generally, the rule in cohort is you should not have a disease that you want at the beginning of the cohort. So the cohort has to be something common. What is common? It can either group of cohort could be PG students in CMC first years. What is common? They're all first years. Or it could be a group of people in the UK in one health system. So in that cohort, some people will have a risk factor, some won't have a risk factor. They're saying the drug is a risk factor. Taking it is the risk factor, not taking it is not the absence of risk factor. And they're following up to see what happens in the long term. That's why it's called cohort study. So generally, the outcome of interest should happen only after the cohort study starts. That's a general rule. Here they try to be a bit, because there are many outcomes. If you have, for one outcome, that outcome, you don't mind including people who have that outcome, that will exclude them from the other analysis. And you will be a bit careful. The other thing about this cohort study is interesting is generally, like suppose I'm following up all people in CMC 10 years later where they are. We generally follow one group of people getting money. They what they're taking is because they have large databases. You can take people from many parts of UK and follow them up. So the cohorts could be many cohorts mixed together, as long as they have similar kind of data. The advantage in UK is a very good health system data. So as soon as 90% of the population goes to the government health system. So this cohort, the bias, the selection biases, it doesn't include very rich people who still go to private health. For example, the private insurance, which is he doesn't go to NHS, he goes to private. This data will not find his data. So in that you have people in the NHS, and they are part of like people in Vellore is one cohort, Chennai is one cohort. Practically all the same people, you can mix them both together as a cohort study. How do you identify people who took the drug? You don't go and ask them. Because everybody in UK has to buy the drug through the health system. The health system will identify the drug. Now, you put psychotic, antipsychotic as the intervention. They are not putting antipsychotic. They have got a British formula under which it is captured. So under that, let's say, antipsychotic comes as drug B1.1. So you just say all B1.1 is drug. People are not taken B1.1 across controls. So how do you identify the exposed and not exposed? So the problem is, why I'm saying this is only increasingly the West people are taking this data from what is called administrative data. The hospital says CMC medical record. Now let's take an example. Okay, all those on CMC staff are following up for 10 years on antipsychotic cohort. How do I go to CMC staff to get the hospital numbers? How do I antipsychotic? I look to a pharmacy record to the able to prescribe. But many CMC staff may go to outside psychiatrists because they don't want to run it. So it is. But here also in the system, if somebody went to a private psychiatrist and got antipsychotic, you miss the system. The controls are people who did take antipsychotic. But the same problem can happen to them. If you identify them only based on the system of not having drug, they well might have had some issue and taken the drug also. The other thing is somebody talks about administration of the drug. Like, how many of you ever had antibiotic in your life? Ever? Did you finish the food course? So this is when we take this kind of person, it's not about whether you took the drug, whether you were given the tablet. You don't know how regularly you took the tablet. Those kind of things will be missed. But if you want to do lakhs of people and follow them up, these administrative database are easy. But you understand the flaw which comes inherently, that is just okay. I was prescribed a drug, or the system says you were prescribed a drug. Whether the patient went and took the drug from the pharmacy. GP has prescribed in your name. You might have never gone to the pharmacy and taken it. You might have taken it home but never taken it. Or taken it but took incomplete. All those things will not be captured. These can just go back to another one. This good thing for everyone to learn. See, now increasingly in CMC, only few units are taking the drop down menu for diagnosis of inpatients. Suppose I want to know in CMC how many dementia patients are there. The dementia may not be picked up in the final diagnosis, but I can use artificial intelligence or some computer software to pick up diagnostic codes. So those are those codes, snowman codes, abyss codes. So those are technical methods of picking up codes for diagnosis, codes for drugs, codes for lab tests. So increasingly people all over the world are saying, if everybody in the world uses, or at least in India, uses the same code. So you know the name of a coding system? ICD, International Classification of Disease. So most countries in the world follow ICD classification of disease. But that does not have ICD classification of drugs, ICD classification of lab tests. So for that we are doing snowman for lab tests, for drugs there's a separate classification. So as long as people use a common coding system, then we can say that system applies to us also. Okay, because they all compulsorily have to use the NHS system. Everything is coded there, they are able to get a large group of people. Some people who are called dementia by the, totally people with dementia misdiagnosed by the system. Yes. There is somebody on temporary memory loss, depression diagnosed as dementia. Some people with dementia missed by the system. Yes. Not everybody with dementia goes to hospital. This is among those who went to hospital who happen to be diagnosed. That is the inherent biases in these kind of cohorts. The question is, was a cohort recruited? You will understand that increasingly in the West they have cohort of 1 lakh people. They go and check 1 lakh people that you have dementia at the beginning. Do they physically follow them up? No. They are following them up through the chart. The onset of the cohort is in the chart the day you were diagnosed with dementia. Then they are following up and see, okay, were you taking antipsychotic or not? And through the chart they are following up to see when they had a fall or not. So it's all done through the chart. So even fall. Every fall will you take your dad on one to hospital? No. So those falls will be missed by the system. And unlikely that a fall is misdiagnosed. The only condition where a fall is misdiagnosed, somebody had a minor stroke and fell down. But that is taken as a fall. It's not a fall, it's really a stroke which made it fall. But here it may be taken as a side effect of it. So there is a chance for misclassification of these kind of things. So this is whenever you do large databases, these kind of things. So what they do is, okay, they accept these are our potential flaws. They say in 10% of patients we go back and recheck whether all our assumptions are correct. And they say 90% of times it was correct. Therefore, overall, the data is 90% accurate. But very few cohorts will actually go and say 10% of patients will actually go and ask the patient, oh, you diagnosed dementia on this day. Oh, you were given this drug, you take it. Oh, you had a fall, you actually fall. So you should do those kind of things when you have these very large databases. Exclusion criteria?
Someone who was already prescribed an anticholinesterase for before even the dementia diagnosis, they have excluded and any specific This is the whole flowchart diagram of both the databases RM and GOLD. How they have excluded it based on the data here, based on the CR equality. They have the data at all. They started anticholinesterase prior, antipsychotics prior. If there was death or the outcome even before the index date itself, and the patients who were less than, so adequately they have excluded the patients who had exclusion criteria and did not form into the.
See, just go back to some important thing there. People who migrated from that area, the following of a group of people. Normally, if you follow a cohort of people, some are following 100 CMC staff. After 1 year, 20 of them might have moved to some other hospital. That's a normal part of cohort study. And I would say also follow. Here they are only including people who have not moved out of the system. So in a sense it's a bit of an artificial cohort. Because normally in a cohort you will have people moving out. All they've done is even before you put, because it's all retrospective, if you are not followed up completely, you are not part of the cohort. So these are not normal things. So you should be able to identify them as a part of the cohort. Okay, go on.
This is the overall study design flow diagram. So here, they initially say that there is an entry date where the patient is actually entered into the cohort itself. So where they have the date of diagnosis of the dementia as the initial statistic which they consider as an entry date. So during that time they still exclude based on anticholinesterase if they started prior, if they have been on an antipsychotic 365 days prior, and other exclusion and inclusion criteria they will look for. So once they have entered into the cohort itself, they have waited till the index date. So the index date is taken as the first antipsychotic prescription. So during this time there could be patients who are exposed and unexposed. The time when it becomes an index date or when they are exposed to the drug itself, they become into two groups. Okay. One is the exposed group and other is the comparator group. So during which time, again as previously mentioned, if they had the outcome prior itself, they were removed. Even prior to the index date itself, they were removed from the study and excluded. And there were other things like lifestyle factors and comorbidities prior to the index date, they have excluded. Two prescriptions before in the 365 days before the index date, still they were excluded. So they have adequately done enough exclusions to remove people which could be confounding the outcome itself. After that, they have done exposure assessment. They have based on the prescription. They have continuously monitored whether the prescriptions have been given again and again. We'll come to that later how they classify them as different users. So then the follow-up went on till 2 years, or at least 31st May 2023, 2018. So was the exposure accurately measured to minimize bias? So this I felt it was a no. As Sir already mentioned, we thought there was no evidence of dose of the drug which was given, compliance of the drug, whether any interactions was it given by this being dementia patient, was it given by the self, was it taken by self, which patients can miss doses, caretaker given it or not, like those questions were not adequately answered in this study. So what they have given is just the date of first antipsychotic prescription is loaded onto the database. That would not really measure the amount of drug they were on, the dose, the exposure, how many days they have been on, everything could have been missed, and that I felt it was a no for this question whether the exposure was accurately measured. So the comparators again, how did they allot comparators? So this comparators is allotted using incidence density sampling. So I'll come to that in the next slide. So how they allotted this comparators were people who have not been exposed to these drugs at all, at least on the day of dementia diagnosis or at least 56 days after. So in incidence density sampling, so if we take it as a cohort, what happens is, so some patients who are at the time of index diagnosis, and the date when they start the drug itself is called the index date, and since then they are considered as exposed individuals. Some patients, since after the diagnosis, still will not be exposed to the drug, so they are considered to be comparators. But at one point of time, they might require the antipsychotics itself, and at that point, they can become exposed individuals. So this is what incidence density sampling means. So at a single point of time, if this patient is going to be exposed, so he has to be matched with the comparator who was not exposed at all at that point of time, who can become exposed later at a later point of time. So at this point, this exposed patient will be matched with up to 15. So it could be anywhere from 1 to 15 random individuals who are not exposed to the drug itself. So it could be this person. But at this point of time, this person again will be matched with 15 other comparators who are not exposed. So this is a statistical method to do is incidence density sampling. But as I said already, I felt it was not accurately measured. So they have mentioned that both atypical and atypical antipsychotic use, again dose is not mentioned, so they classified them as current use, recent use and past use. This is the only way we could identify whether they were on continuously on the drug or not on the drug. So what did they mention mention the definition for current uses? First 90 days. So this is an example of a patient. So say this patient at 0th day has entered into the study, was given the first prescription around say 20th day. So from here, you would consider anyone to be on current use for till 90 days of this prescription. So once this prescription ends, if they are given another prescription, it resets. So from here, from this 90 day plus 90. So it keeps increasing till the last prescription. So in this situation, you can see that the patient got around 28th day, probably 90 days, and got another one around say 100 days. From here again, plus 90 would be 190 days. So they consider them as current use. And then on, anything after that for 180 days is considered as recent use. So they are not given any prescription, they are not on the drug. And then later on, after this 180 days, it is called past use. So with this, it gives an idea whether the patient was on the drug actively or was it in the recent past or is it in the real past. So that they have mentioned clearly, and they have differentiated patients into 3 groups. This is the only way we could actually identify whether the patients were on the drug or not. But other data is missing. So was the outcome accurately measured to minimize bias? So the outcomes which I have already mentioned, these are the 8 outcomes which are all subjective outcomes. So the mean says is that subjective or objective. So these are objective outcomes which again were coded into the database. So as Sir already said, there could be missed data, there could be expertise level of the outcome necessary could have been misdiagnosed. All those are confirmed probable biases which could lead to loss of missing data in this cohort, which will lead to the outcomes being really under reported. So might not be real liable, so I felt I couldn't tell much about the outcome itself because these could be factors which would affect the outcome. This was a retrospective cohort study that there is no mention of blinding. So the authors identified all important confounding factors. So they have mentioned in the article itself, they have went into literature and they have checked all possible risk factors and factors which would be associated or as a correlation with dementia itself and the progression of dementia. So they have adequately listed out all confounding factors and they have done adequate analysis for each of them and compared them with the outcomes also. But things which they have missed out is what the ones which they have missed out I felt was stroke in the past which could lead to further falls in the future. Sedentary lifestyle again has a positive correlation with dementia, higher risk. Gait dysfunction prior again can lead to more falls in the future. Hearing loss, vision loss again can lead to more falls in the future. Falls in the past which they have not mentioned if any, and sleep disturbances was not mentioned. So one other thing which they have mentioned something called deprivation scale, deprivation index, which is done in the UK for all population, which includes all these domains: income, employment, education, health, crime. So why they mention this is because education and employment also has a positive, inverse proportional risk to developing dementia. Someone who has a low educational status has a high risk of developing dementia. So likely though they have done that, so that was adequate. So I felt most of the confounding factors were identified, but to my case scenario, these things were not adequately addressed. Have they taken account of the confounding factors in their design or analysis? So how did they? So there are some baseline characteristics which we see at the start. So the groups were entirely different, and this is a cohort study. It is not going to be randomized as such. So to do that, to achieve a unit of randomization or to make the groups a little bit equal, they have done something called as a propensity score method, which is a propensity analysis. It is a statistical method to achieve or mimic randomization, such that both the groups are equivalent at the baseline characteristic level. So what they've done is they would run into this model where they've run for each outcome or each baseline characteristic, they've run a propensity score. They have used this program, data program, according to this article, Lund's article. Based on that, they found the propensity score based on the multiple variables and keeping the dependent variable as exposure to antipsychotics. So based on this, they have achieved the propensity score which has a range. So there are common support in anyone falling below very low propensity score or anyone falling above which is very high propensity score, they are excluded from the study. So propensity score just gives you an idea that how much is the probability of the patient getting exposed in the future. So a little bit more to understand. So this is how the population cohort would have been. Based on this, they would have got a propensity score. They would have matched based on that between the comparators and the exposing population. And if they are lesser than the propensity score, they were excluded. Lesser or more than the propensity score, they were excluded from the study. So that it seems a little bit randomized and equal at baseline. So this is the table they have given the supplementary where they have weighted for each outcome based on the propensity score to check whether they give a range between minimum and maximum. Anyone behind the minimum or below the minimum propensity score, they are excluded from the outcome analysis. So coming to the baseline characteristics itself, so this based on the propensity score, they have done another statistical analysis to give weightage to each of the baseline characteristics based on whether they are users or comparators. So before IPT weighting, you can see along this there are some differences which are like 3% to 4% differences, or which we can see in the baseline characteristics. Which after weightage, they have it is almost similar. The amount of baseline characteristic difference has significantly come down. I'm not going to detail in this because all are actually similar at the end of the IPT weighting stage. So the follow-up of subjects complete enough. So they have overall followed up for 2 years, but they have done hazard ratios for individual cut-off follow-up time, like for 7 days, 8 to 30 days, 31 to 180 days, And I felt that the 2-year follow-up was long enough to understand whether the outcomes are relevant or not, or can you give causation to association with the drug itself for the outcome. So for each outcome, they started follow-up right from the start of the antipsychotic prescription and till the date of the earliest outcome. So or till 2 years at the end of the study itself. So if they had the outcome within the 2 years of the study itself, they would have accounted. Anything above that would have been missed.
No, that's not the question. For harm to occur, what is the biology of, if you give antipsychotic, when do you expect a stroke to happen? The classical example is this drug which is called Ropicox. Cox is the painkillers given. Most painkillers are what side? Yes, right. So they invented a painkiller with no characteristics. That was the Coxes. And everybody in the world started taking Ropicox. We were prescribing like water. We became the highest selling drug in the world. And then after some time we noticed that many people were dying. Why did a person who has got arthritis and backache die suddenly of heart attack? Then we asked the company, why did you not, were there more deaths in your study? They said our outcome of the study was 1 month pain relief. So we had a randomized control study. One arm got Ropicox, one arm didn't get Ropicox. And the outcome was only pain at 1 month. We also looked at side effect at 1 month. Pain came down dramatically. The placebo arm pain didn't come down. So we said, very good. No, but we asked about mortality. Oh, yeah, many people died in the Ropicox arm. Why did we not report mortality? See, we only reported 1 month outcomes. Nobody asked us to report 3 months, 6 months outcomes. True story. The pharma company had to pay billions of dollars. Fine. Nobody went to jail, but anyway. So the side effects often take some more time to occur. The pharma company knows it. So they will not follow up people for long time. They will keep a short of follow-up as possible because harms take time to occur. So now, how do we know them? Now we will say, oh, Ropicox goes, it causes some thrombosis, it causes some cardiac dysfunction. That MI will start appearing after 1 month, 2 months, 3 months. So the benefit is already there, because suddenly they are dying. Individual doctor will see 1 or 2 patients of dying a year, he won't connect that to Ropicox. But if you look at the global data, you can quickly do it. So even in this cohort study, the question is biology. How does antipsychotic cause stroke? And okay, if I follow them up for 3 months, 7 days, nothing will happen. How can antipsychotic cause stroke? Maybe after 3 months, it will cause some thrombosis, which will cause stroke by 6 months. So we must have some biological rationale to answer the question. Was follow up long enough for arm stroke? So we are really looking at arms. Okay.
So up till here, the study was a valid study, but there were some pitfalls which could have been addressed. So we'll go into the results.
But before that, this is a thought process where we cohort study, critical appraisal. You should try to think of it like a randomized control study. A good cohort study should mimic a randomized control study. What is good in randomized control study? We have a group of patients who reflect your patients. That's called selection bias. Have they chosen patients who reflect our patients? What is the baseline age, gender?
The baseline age at dementia diagnosis, which
Was
is
80 years. 80 is slightly older than our patients. Correct. And gender-wise, mostly men or mostly women in India? They seem to have slightly. I think that generally, if you find older people, women live older than men. That reflects UK population. I don't know whether you find older Indians, there will be more women or more men. So that's not their selection bias. We are trying to look from our perspective. Okay, there's no selection bias. Next thing you do in randomized control studies, when is the date of onset of the study, randomized study? From the date of randomization when you got the drug. So here is the date of diagnosis of dementia. But the thing is, many people, dementia is diagnosed when the patient came to hospital. They might have, different people might have had dementia for a long time before they came. So that is one problem in a cohort study which we can't overcome. Here they said dementia, no dementia from the date of diagnosis. But you might have a varying time point before the diagnosis of dementia. And the complications of dementia start from the time you actually had dementia, not the time somebody diagnosed him. This is called time zero. In a randomized control study, time zero is the date or the minute you were randomized. But actually, in a cohort study, time zero is here the date of time when you are diagnosed to have dementia. So there's a slight difference in time zero here. That is not possible to do, overcome it, but you must start taking. The next thing is we try to randomize so that the baseline characteristics are equal in two groups. So that the difference is only because of the treatment. If the two groups are identical twins, then how you follow them up, the only difference is because you gave one group one treatment, another group another treatment. Here at baseline, in a cohort study, there will always be differences. Because the people who took antipsychotic are quite different from those who didn't take antipsychotic. There will be some differences. So, how do you overcome that in a cohort study? They have done what is called this propensity matching. In a sense, it's like, okay, in the antipsychotic group, there's a woman age 50. Now I take a woman age 50 and the people who are not taking it. You don't physically do that. You do it. You can, one thing is to ignore this completely, accept lot of differences and adjust it by doing regression analysis. Baseline differences are there, you do a statistical trick called regression analysis. But if you do a regression analysis, people will see, oh, baseline characteristics are not equal, they will be unhappy. To overcome this, you do a trick. It's not a trick, it's the same extension of the logistic regression. You do this propensity score. In the propensity score, you will find there are 5 lakh people to begin with. 1 lakh people take antipsychotic. That's your group. You want to match baseline characteristics of 1 lakh. Among the remaining 4 lakhs, you will find people. You find, oh, okay, the element looks like a randomized control study. So the baseline characteristics. See, they have taken one for every 5. So the baseline looks equal. But there are many people who are not included in the comparator group. They are selecting people to make it look equal. Why? How does that magically happen? By a statistical technique called propensity score. Then people will firstly think, oh, this is like almost as good as randomized control study. Baseline characteristic equal. Where it fails is randomization makes baseline characteristic of known prognostic factors equal as well as unknown confounder. So here we can't do the unknown confounder because we don't know what is unknown. So we have to accept that. Other many people say, oh, this is a pseudo randomized study. It's almost randomized study. No, it's not. It's just a simple cohort study. Instead of logistic regression, you have put a fancy word propensity. You should not assume that. But you must try to make, so this is a study as well as a cohort study. We are trying to make it look as good as the next thing. The loss to follow-up, how much was it in both arms? Are they giving you? So they should actually tell, because they know now, no. So the time you took antipsychotics, you are part of the trial. How many people were there followed up? So they should tell you loss to follow-up in both arms. That's an important part. Then only you know. They could have clearly have captured that information. Because they know everybody who's in and out of the system. So they are not told you the loss to follow-up in antipsychotic arm. The people who are lost to follow up maybe because of side effects. Maybe they fell and got out of the study and I don't want to go back to the doctor. Then that's a big risk in your study. The last thing is blinding of the outcome assessment. Now at a randomized control study, you say the person who is determining whether you are MI or stroke or fall, they should not know whether you took the drug or didn't take the drug. Here we have to sort of guess. Would that person have been able to look at the chart and see antipsychotic or not? Would that knowledge have affected their diagnosis of stroke or not? You have to make an educated guess. Because these are all captured by the system, you have to just assume that likely cannot happen. But how much would it have been affected by the knowledge of antipsychotic in the chart earlier or not is a matter of question. So in your mind, when you look at a course and you start imagining, oh, what are the potential differences between it and an ideal RC? Because all those are biases away from the truth. You will find a nice odds ratio or relative risk, and then you forget that this is a cohort study which had a lot of problems. That you shouldn't do. Okay, let's see that.
When we do in a cohort study, which one is better for superior when we do critical analysis?
There's no difference between doing a logistic regression analysis at the end and doing propensity score. If you do propensity score, you can show a baseline characteristic with both equal. Because now it is very nice. If you didn't do this, you will put 24,000 antipsychotic, let us say 3 lakh non-antipsychotic, and the male will be 35, the male will be 70, age will be 50, age will be 70, and you say, oh, based on so many different, let us do logistic regression for all these. But instead of that, if you do propensity score, it looks slightly better. It's not an advantageous thing.
So coming to the results of the study, overall results they measured as number of outcomes per questionnaire and the incidence per 10,000 questionnaires. So I just looked at the outcome from my scenario itself. There is a difference of, you can see the outcomes of antipsychotic users were 626 while matched comparative was 7,088. If you take it in, because there was difference between the numbers in the comparative group and the exposure group, that's why it seems a little bit different. But if you convert it into person-years and incidence per rate, it comes to 825.1 per 10,000 person-years with a confidence interval of 762.9 to 892.3, which is a little narrow. While the match comparators they still had faults, but comparatively they had a lesser incidence rate, which was 575.4 incidence rate per 10,000 person-years. They have also calculated based on this, they have calculated the number needed to harm, which is coming to 40 for an antipsychotic user. So 40 patients you treat with an antipsychotic, one patient will have a fall or fracture. They have also given a confidence interval for the NNH also, which is from 32 to 54. So this is at the end of 180 days. Again, they have also given it at the end of the total follow-up, which is 2 years, which comes to 777.1 versus 556.2 incidence rate per 10,000 person-years, and the number needed to harm is almost the same, which is around 45.
So usually in a cohort study, we see incidence in one group divided by the incidence in another group. At baseline, we don't have disease. When you want to do something, you use called incidence. When you divide one by the other, what do you get? Incidence in one group divided by incidence in another group. Relative risk. Cohort studies, randomized control studies usually provide you relative risks. So we can actually do 725. It's not actually 725 per patient years. Anyway, 725 by 575 is roughly about 1.5. 800 by 500 is 1.6. Roughly 1.6, something like that. So the relative risk is 1.6. So how do you get NNT from relative risk? You look at the baseline risk. So in the group which didn't take antipsychotic, what is the risk? If you multiply that with the relative risk, then you find the absolute risk in the other group. Then you can come to number needed to harm. So you have the baseline risk in the other group here, and you can multiply that and you can get the absolute risk. They have calculated the number needed to harm for you straight away. So they can present it as relative risk, or they can present it as this way. It does not do that. It doesn't seem to change between 6 months and 1 year, right? And 2 years.
Not much difference.
So the risk remains the same. It doesn't keep on increasing. Okay. Sometimes you can even give the I can give a CAP survival curve. Where you can see the curves may separate for some time and they remain the same. So the risk increases up to 6 months, then after that the risk doesn't seem to change.
They have not given a survival curve in this.
They could have given for each outcome, they could have given.
Is there a way to go back and check if this data is correct? So have they calculated it correctly?
No, they can only ask them to give you the original data and try to get the data. Okay.
So this is hazard rate. They have calculated hazard ratio again for different time intervals from 7 days till 2 years. Again, I have looked at fracture itself. So here they have differentiated into current, recent use and past use. Here initially within the first 7 days, which will come into the current use, they had a hazard ratio of 2.22, which means almost 0.22% higher increased risk of falls in the patients who had taken antipsychotics. While at the end of 2 years, it comes to 1.53 in a patient who had current use. Recent use is 1.61 and past use is 1.07. Again, it comes to around 53 to 61% increased risk of falls in patients who have been exposed to the antipsychotic compared to who have not.
Okay, let's just take one group, 181 to 365 days. Who will have the highest risk of a fracture? Antipsychotic causes low BP and will fall. Will the person have recent use have highest risk? Remote use or very distant use have highest risk? So is there a gradient like that? Is there a difference between current use, recent use and past use? Not very much, 1.29, 1.28 and 1.02. The confidence intervals, are they overlapping? 1.14 to 1. Even the last one, 1.5, is overlapping other. So we are not seeing a relationship between time and. If I take antipsychotic today, the next 7 days, I must definitely have higher risk than somebody who has taken it and 1 month later if I fall, I can't say it's the same as somebody who is recently taken it. So there is a, but the follow-up period for the current use seems to show a relationship. No, the current use, the first 7 days, the risk hazard seems to be 2 times. After that, it seems to come down and down as time goes by. There is some evidence that the risk is maximum in the first 7 days after taking. So what's the difference between hazard ratio and relative risk? Same. Relative risk is simply the incidence in one group. How many had fall in one group divided by how many had fall. The percentage you had fall in one group divided by the percentage you had fall. Hazard ratio is time to fall, how quickly they fell. So hazard ratio is an advanced method of cohort study or RCT where not only fall, how quickly you fell. So the interpretation is like a relative risk odds ratio, but it's a slightly more complex number. That number includes whether you fell and how quickly you fell. So that hazard, that's why they are presented as hazard ratios. So there seems to be a gradient in the way we are thinking, because we are looking at harm. Harm should be maximum after you take a drug, and as time goes away from taking the drug, but the follow-up, no, this is not time from taking drug, this is follow-up.
This is follow-up period after starting of antipsychotics.
So that the risk should actually increase, should it not? As you take more and more drugs, the risk should increase.
Okay, the current use is up to 90 days of taking.
No, in the current group alone, the risk should progressively increase as you keep taking the drug, right? You think about the biology of the drug. So give you antipsychotic, and you continue to take the antipsychotic, the risk will become more and more and more. But they are saying the risk is maximum in the first 7 days, after that risk seems to progressively start coming down. Because of like the body attached to that. That should be the explanation for that.
Maybe in that case, like, because current users are people who had a prescription and if they are continuing to be current users, they got prescriptions again and again.
Yeah, but so let's say I take it for I'm taking it for 90 days or 30 days. As the 30 days goes on, my risk will keep on increasing compared to the first 7 days. Right? But here they say the risk is maximum in the first 7 days. Then the same person who's continuing to take the risk seems to come down.
So most of the patients are like 80 years of age, so if they had a fall and a fracture and they had surgery, then they may be 24 hours to next fracture was like a.
That's a very important point which he brought. What is that called? Anybody know? Cohort study RCT, this is called competing risk. So can you put up the outcomes in your study? These are the outcomes. So in a cohort study, a randomized control study has 8 outcomes. The moment you have one outcome, you are out of the study. So suppose you had a fall at day 2. After that, even if you have stroke on day 3, you are not counted in the study. So this is called a competing risk analysis. So if you don't take competing risk, most of this Kaplan-Meier curve, survival curve, it is timed to first event. You have a composite outcome of 8 events. Which is the first one you take? Now, suppose like God gave you a choice. You have one of these outcomes. Which will you choose? Fracture. Okay? Suppose you had fracture on day 2 and you lived peacefully after that. Suppose you had a MI on day 3, that will be a bad thing. But let's say you had MI at 1 year later. You had a fall in 6 months. Then we say you had fall, very bad outcome only. But you had MI at 9th month. She had MI at 1 year. Who would be appearing to be worse in the study? No. You had a fall at day 6. After that, the MI is not counted in the study. Your MI at 9th month is not counted, but for her MI at 1 year is counted because she had nothing till the time. So you see the problem of this time to first event, where the first event eliminates you from the other events, is called competing risk. So now people are increasingly doing, and overcome this by doing many methodologies. One is called generalized pair-wise comparison. To do a analysis of overcoming this particular problem. There is one issue which, like if you have a small after they are not part of studying, I don't know how they overcame.
I think they have mentioned there that even if they had one outcome, they still were considered for the other outcomes as
So they have to write those kind of analysis.
Even in the supplementary, like individual.
So they have to mention how they decided to do those analysis and how did they keep people still in the analysis.
So, yeah. So this is the next table which gives you cumulative incidence of adverse events at 90, 180 and 365 days. Again, I'm looking at the fracture at itself, which again gives you an incidence rate of 1.88% compared to comparators at 1.42 at 90, and 2 years is around 9.99 and 9.50, which becomes almost equal to Indian incidence.
9 per 1000?
They have mentioned the cumulative incidence percentage. They have not mentioned out of 1,000 or 1 lakh.
Percentages per 100?
It's
That
coming
means-
up equivalent to us.
No, I'm saying that means difference is 0.49. Which is on one side of one. So they give bigger than 0. So they say it's significant. It's not very hugely different. Okay, go on.
So this is the forest plot they have given in the article, and going into fracture alone. Again, here between current, recent, and past, you can see that the primary endpoint hazard ratio is 1.43, which is the confidence interval which is very narrow for current, and recent also is on the other side, while for past it crosses and confidence interval is wider. While if we take the whole cumulative hazard ratio, which is on one side with a very narrow confidence interval, 1.3 to 1.44 with an primary endpoint of 1.36 hazard ratio, means 36% more increased risk of falls in an antipsychotic group. While
Of course, fracture.
fracture, sorry. While every other, if you take every other outcome, again for past it's always crossing the midline or the null point, while for current and recent it is always on the other side, significantly other side with the confidence interval is not crossing the null point, but every other past event it is crossing null point. So every outcome was significant with a higher risk except for ventricular arrhythmias, which was not significant. There was no difference between both groups. I didn't understand this negative control of
Negative controls, people who didn't take the drug. You just keep, you control people who are negative control. There are two types of negative. People who didn't have dementia at all or never had antipsychotics ever. See, your incidence density methodology, somebody who was antipsychotic free, after some time he would have been controlled. At later date when he got antipsychotic, he was taken out of the control and put the other arm. Somebody who never through the whole duration would have been the negative control of it.
They have, at the end, they have also looked at what are the different antipsychotics being used, and most common was the same one which we also use at time, but Decadent is the result which is coming 28 and 29, followed by haloperidol, which is 10.5%. So how precise are the results? As we saw, the results were precise, the confidence intervals were narrow except for the past users. So do I believe the results? I would say yes. Because even though the study was done, there was some pitfalls in terms of the assessment of outcomes itself, but overall the risk hazard ratio suggests that there is a difference, and I think that comes up well. So for that I am going to Bradford risk criteria for assessing whether the outcomes are valid. So platform fit criteria is for assessing whether giving a causal association of the exposure to the outcome. So for that, there are different domains. First one is temporality, that the cause precedes the effect. So here they have assessed from the start of the antipsychotics till 2 years, and obviously the cause was prior, the exposure was prior to the effect itself. So that it's out. Then plausibility, the association consistent with the existing knowledge. There are several other papers also which suggest the same, and there is a significant association between use of antipsychotics, gait imbalance, fall, low BP as mentioned. Was that consistent?
Plausibility is also biological plausibility. Does it cause postural hypotension?
Certain antipsychotics.
That's more a biology of physics. So how do you explain that fall followed by fracture? Does it cause osteoporosis? So you must look at these kind of methodology. Okay.
Have similar results been shown in other studies? I'll come to that in the further slides. I have quoted some studies. Strength of association between the cause and effect, we saw that hazard ratio was 1.35.
So just remember that. Hazard ratios and odds ratios, little is more than 5, 10. That will make you say, oh, there is something. 1.2 means like, okay, slightly more than nothing. 1 is nothing. 1.5 is 1.5 times. So 1.2 is not a huge effect. So we say, remember, is there an association between taking antipsychotic and fracture? Yes. 1.2 is a 20% chance more. Is it causation? We can't say. We are trying to jump from association to causation. Is there association between putting the switch on and the light coming on? Yes. But it's not causation. By putting the switch on does not cause the light to come. It's the electricity which we are not seeing. So we don't want to jump to the wrong conclusion that antipsychotic cause fracture. Is there association? Yes. But for causation, these are the nine. So for strength of association, generally with the hazard ratio, odds ratio more than 5, 10 and on more. That's not a small thing. That's a huge amount of risk. Especially the confidence interval is high. Protective effect 0.5, 0.1. And you say, oh, those numbers are really something. Don't ignore it. 1.2 is okay. So the pharma company will say, we are just thinking about 1.2. They will not do that. Okay. 1.
So does increased exposure equate to increased effect? There is not a mention about the dose itself, but we know that during current use,
that is dose response here is ulta. Recent users had higher, immediately after taking the drug, you had higher fall, it seems to come down. So we thought, we are also confused, like, the more you take it, the more fall should happen. But the fall happens the first week after that, even if you continue, the fall doesn't happen. So there is some.
Towards the end, after 2 years, there seems to be a trend in increase. 1.29, then 1.5. Maybe initially it's first dose hypotension, and then stabilizing, then maybe osteoporosis.
There may be an increase again. So we have to look at it like that.
the survival curve they've given could have been.
We could have seen what happens. Again, if the survival curve was the first event, it's difficult to interpret. But the first, if it did not, they excluded any event, then you can do that.
A reversibility does removal of cause, again they have not mentioned per se, we could say that in past use was something.
Yeah, there is a past use. If you stop taking it, then there is one back to normal.
Lesser. Is the evidence based on a robust study design, except for that pitfall of outcome assessment, I felt
What would be a better study design?
RCTs, but harms we can't do.
So, would there be a patient, would dementia patient require antipsychotic in normal conditions?
I think so it says severe psychosis and
Yes.
severe.
So, I'm sure there are many randomized control studies of antipsychotics for people with dementia. But if you look at individual RCT, they only have reported few harms. So you can do a systematic review of many RCTs involving antipsychotics for dementia. And in that slowly the picture will emerge. If you combine many studies, oh, there were harms. The advantage of using an RCT for that is the baseline characteristic is same in both groups. So there is no, that bias is not there. The difference you're seeing is truly because of drug. It is not some residual confounding. Here, even though you say study design is robust, we did that methodology of regression analysis, or we did some other fancy technique. Unmeasured biases, confounders will still be there. Like reason blinding is not made. Loss to follow up not measured. Time zero. When is the beginning of the patient's diagnosis? All those things are not possible in a cohort study. So we can, even though this is not this is the best one can do, it's not the best design visualization. Okay?
How many lines of evidence lead to the conclusion? I've looked at other articles and come to that. So before that, can the results be applied to the local population? Ideally RCT, but it's not ethical to do.
We're not doing the RCT to induce harm. I'm not giving you antipsychotic and saying let me see if you fight. Antipsychotic because they have severe psychosis. Right? You need to look for fall and fracture. So we should have looked, they could have looked at the systematic review of fracture and antipsychotic.
But is it possible to do an RCT just for harm?
No, you can't do. But how do you do that? Smoking and lung cancer. How can we do? Can you not think? Returns. Smoking to lung cancer. So that gives even one pack of gold flake. Even to be very happy. So instead of going on talking, putting it sleep, what is the gold flake? What do you say? Returns stay out. So what they have done is a smart study. They are a group of smokers. One arm was randomized to intensive smoking cessation. Nurse, doctor, tablets. Other arm routine care. Routine care doesn't mean go on smoking. Every time the doctor will say, please stop smoking. They follow them up for cancer. What do they find? People with intensive smoking cessation have much less cancer than other people. Thereby proving that smoking is causation of lung cancer. So you can do RCTs for harm, but you have to do it in an imaginative way. How to do it? We can't give somebody antipsychotic and say, let me see if you fall. That's wrong. But you can measure fall and fracture in a trial of antipsychotic. That could have been done. That's what they should have done.
So individual RCTs we can never take.
We can. But the thing is, the study is not powered adequately for harm. So the sample size is 100 in each arm. Only one person felt, you say, there is no difference. But if it was systematic, you do 100 studies, 10 studies. Go it. There are around 15 fracture in the antipsychotic arm, only 2 in the other arm. Oh, there's a difference. So systematic reviews are very good for harms. The advantage is data is equal, so the difference has to be proved. We can look for that.
So in smoking, for example, if you give one arm something to like pharmacotherapy for smoking, will it become unethical or not yet?
No, the other arm, placebo arm, you can't say don't say please continue smoking. What is the current standard of care in the medicine to OPD for smokers? Please stop smoking. But how I refer them to nurse? We give one meeting, stop smoking. Now, we're not proving that it will be beneficial. We're just looking whether the intervention is beneficial. But we're also looking to see whether cancer comes down. Having stopped smoking if cancer comes down is the indirect way of saying that smoking what cancer causes cancer. Previously, there's one other thing that go back to the Bradford includes animal evidence. So you see animal studies, they took monkeys, rats, no, they took rats, exposed them to smoke, cancer. Therefore, the rat is not mammalian. The cigarette companies are not very rich companies. They hired the world's most expensive epidemiologist, R.A. Fisher, Ronald Fisher. The world's full of all these people who wrote all these books. So he said, no, these are useless studies. All of them have inherent biases. Then they took monkey and gave smoke. Then animal rights became. What are the rights of that monkey and that? So now we are saying, okay, take away that animal experiment as a. But we can do another thing. Can I take your lung cells and culture them? Can I expose that to smoking or to nicotine? I can, but that's a lot of work to be done. People can do those things.
Coming to the next part of the slide, where will the results help locally? So can the results be applied to the local population? I said yes. Ideally, I will go into the hints. Hint says whether the cohort study was the appropriate method. So to study harms, the best would be an RCT, but it is not ethical to do as one arm will be exposed to more harm than the other side. So it is not ethical to do such studies. But if such studies have been done for effectiveness, that will be used as a systematic review of those studies of an RCT can give you a harm results, which can be used and applied to the population. Does the population in my local setting differ from that of that in this study? little bit because the patients were predominantly white, but it doesn't make a difference because the overall progression of the disease, the nature of the disease, and the pharmacology and the pathophysiology of the disease and the drug itself doesn't make any changes in these individuals. So it doesn't make a difference, but there might be a few differences between the population in terms of compliance to the drug, follow-ups, and Indian lifespan might be lesser. So the diagnosis of Alzheimer's could be a little bit less incident in our population than in that population. Provided our population also is more prone for osteoporosis and osteopenia, could those factors be actually confounding factors for fractures in our population? Needs some thought. So overall it doesn't differ, but there are few things which we should consider before we realize that this study can be applied or not. So do the results of the study fit with other available evidence? Yes, I have gone through other evidences also. First one is a systematic network meta-analysis, which is published in JAMA, which also said that there was significant cerebrovascular accidents in patients with atypical antipsychotic. This article did not give anything about fractures, so other articles we have seen is this is a second article, which is a cohort study, similar population and a similar drug with antipsychotic medication showed that increased risk of venous thromboembolic episodes and hip fractures with a confidence interval of 1.59 to 1.6 with other ratios or there is relative risk of 1.62. And I've gone into one other study which also shows that antipsychotic therapy were 3.2 more times more likely, while conventional antipsychotics were 3.8 times more likely. So there are other evidences which suggest the same, where antipsychotic use is associated with higher risk of fracture and other side effects. So what are the implications of this study for practice? So going into the hints again, one observational study rarely provides sufficiently robust evidence. So that is what we went into previous studies also, that we have looked at network meta-analysis, which is a meta-analysis of multiple RCTs which have looked at effectiveness, and the harm from that study, harm or side effects in that study also shows higher risk. So there is some evidence apart from this evidence. There are some other evidences which can be used. But for this study for practice itself, I have looked into other evidences. This is a guideline by Indian Psychiatric Society for the use of antipsychotics in patients with dementia. So in their guidelines, they mentioned that low-dose atypical antipsychotics can be considered for severe agitation, aggression, and psychotic symptoms. But they have given a caveat in between saying that it should be considered only if the symptoms are distressing to the patient, caregiver, or if it is contributing to the risk of harm to patients or others. So in patients with very low symptoms, mild symptoms, we would still continue with non-pharmacological therapy for the control of those symptoms. When it's very severe and which is causing harm to the patient, caregiver, or his surroundings, then we can consider antipsychotics because the risk of it is going to be way more higher of risks of side effects. So I've also gone into the cost analysis. Tapering was 25 mg cost 6.5 rupees, which comes to 585 per month, and risperidone comes to around 225 per month. While this is per month cost, we can always calculate for a year or 6 months. But in between, if they have a fracture or a fall with the need for a surgery, that's going to cost 1.5 to 2 lakhs per surgery alone, excluding the IP or the inpatient cost. While a stroke and MI can vary from 50,000 to 2 lakhs depending upon the intervention plan. So overall, I have not calculated the whole as per the number needed to harm, but just with this we can see that the cost is also, like the cost of the side effects or the after effects is much more higher than what this compared to this drug itself. So overall we should make a decision whether this is the right patient to start these drugs on, and with these possible side effects, is it worth continuing it, whether the benefits are going to be worth the risks. So coming back to my patient, the scenario patient, he is a mild Alzheimer's disease patient with an MMSE of 23 with intermittent agitation. The symptoms are not very disabling, nor the patient doesn't harm himself or others around him. So in this situation, what would I do, whether to start pharmacotherapy or not? I would not advise them to be started on antipsychotics based on this study and other evidence which you have looked at. Just this study doesn't give you enough evidence, but the robustness of the study is a little bit query. But there are other studies which support the same evidence. With the holistic evidence, I can confidently say that this is not the right time to start the non-pharmacotherapy, and we'll continue non-pharmacological therapy initially. Maybe start them on treatment for the Alzheimer's itself, and probably follow them up in the future. If it's very disabling or it's causing harm to himself or the caretakers, maybe we will advise them to be started on antipsychotics after understanding the evidence which is possible with these drugs. Thank you.